Can you see my screen?
All looks good. Thanks,
Okay,
Cheryl.
great. So thanks very much, Mignon, for the invitation to speak, as you said, this webinar, which was convened quite quickly. And I was asked to just go through an update on what's happening right now, really, with flu, RSV, and COVID from our surveillance at the NICD. One of the roles of our center is really to monitor these viruses for South Africa. And I'm just going to fly through. What I'm going to go through is three things. I'm going to start with RSV, in fact, and the first thing I'm going to show is, in fact, a mathematical model that we did to try and work out what was going to happen for this RSV season that we're currently experiencing. And then I'll show you the data on what's really happening, certainly according to us. And then I'll have just a few slides on influenza and a few slides on the current COVID situation. So just to start off with the mathematical model, and essentially the data I'm showing here is really what we use to parameterize that model. So we developed this model at the end of last year, and in order to make the model, the first thing we looked at was what is the epidemiology of RSV in South Africa before COVID, and then what was happening in 2020 and 2021. And what you can see here in this graph is really a graph of the percentage of patients testing positive for RSV by week of the year for different years. And this data comes from our sentinel surveillance. In fact, all the flu and RSV data I'm going to show you comes from the NICD sentinel surveillance platforms that operate in a number of hospitals and clinics in South Africa. And at all of these clinics, we systematically enroll adults and children according to specific case definitions for respiratory disease, and we test them for flu, RSV, COVID, and pertussis. So it's a very long-standing systematic platform in multiple provinces that allows us to really monitor these viruses and say, when is the season starting, when is it ending, and how bad is it compared to other years. So what you can see is that in the blue line is really what happens regularly for RSV. And we have a season that peaks around now, just before the winter. And you can see on average, the detection rate goes up to about 35%. And then you can see in the red line what happened in 2020. 2020 was the COVID year. RSV started going up, and then we had a lockdown, and RSV went right down. And then we had some out of season circulation in the second half of the year in the summer. And then it went down again. This is in response to various lockdowns. So the non-pharmaceutical interventions, the masks, the school closures, all of these bring down these respiratory viruses. And then you can see in 2021, last year, RSV, the season started off quite normally. And then there was another increase in restrictions, and that really knocked the RSV circulation, and RSV went down. And essentially, so really, while we have seen RSV, it hasn't disappeared like flu did in 2020 and 21. RSV was substantially reduced. And what we did then was we worked with colleagues at Princeton University to try and project, given that every year we normally see RSV, and this is boosting immunity in children and in adults and keeping down the transmission, what can we expect to see, when everything relaxes? Just this is, in fact, the second part, before we get into the model, this is the second piece of baseline data that they looked at. It's quite interesting. So what we saw already in 2021, so following a year of 2020 where there was no RSV circulation, we started to see in 2021 already a shift to older children. So we know that RSV hospitalizations predominantly occur really in the youngest children, and it's not really, we don't know entirely to what extent that very young age distribution is influenced by the fact that infants have an intrinsic susceptibility to severe disease, or how much is driven by the fact that attack rates are really high, and so most infants get exposed very early on in life. The fact that we started to see the shift to slightly older children suggests that some of the severity is in fact influenced by prior immunity, although certainly probably a big part of it is also affected by intrinsic severity. So there were two things really: how big would the season be, and who would be affected, that we were trying to model. And then we built a model. Essentially, this is calibrated on existing data. You can see there in gray the various lockdowns, and so parameterized on what we knew for 2020-21, we try to project what will we see in 2022 if everything relaxes completely. And essentially what we predicted was an intense season, slightly early starting, peaking in April, and then also very interestingly a shift towards older kids. So a 32% increase in hospitalizations compared to pre-RSV, so a big season. And then although there's still the most hospitalizations predicted to be in the youngest first 2 months of life, we see this prediction that we will see older kids admitted to hospital who maybe wouldn't have been admitted before. And these kids would have missed infection in 2020 and 2021. So what did we see this year? You can see this shows RSV from our pneumonia surveillance going back to before the pandemic, again showing this very unusual sort of out of season suppressed circulation, 2020, 21, and I'm sure all of you pediatricians out there are now seeing this very big RSV season. In fact, in terms of absolute numbers, the numbers we had projected it to be higher than an average season, and in fact, the numbers are looking quite similar to preceding seasons, sort of on the high side. And I can just show, this is another way of looking at it. This is our MEM threshold. We really set these thresholds based on previous seasons before the pandemic. And we define the start of the season when it goes into the low zone. And then depending on how high it goes, would be the severity of the season. So these thresholds are set based on previous years. And we can see this year's season sort of peaked just at the interface between high and very high. Very high would really be exceptional, an above average season. It's going down now, but I would just caution that some of this can be a data lag. So we're really in the middle of a very severe high RSV season, not completely out of the realm of a normal season, but on the very, very high side. So that's it for RSV. What we haven't looked at, maybe Shabira some data, but we haven't looked at the age distribution. We've heard early on we looked and we couldn't conclusively see the shift to older kids, but that was in the first few weeks. I think now we'll have the numbers, but I wasn't able to do it in preparation for this. But I think anecdotally, many clinicians have also said that they are seeing older kids with RSV. And all of this, of course, is a response to the immunity gap that was created by these viruses circulating at much reduced levels the past 2 years because of our non-pharmaceutical interventions. Now, what about flu? Flu was also dramatically affected by the non-pharmaceutical interventions. Essentially, we didn't have a flu season in 2020 or 2021 during the winter. And this graph just shows, historical data in the top from our outpatient surveillance, the bottom from our hospital surveillance. And for many years, this gray is winter. And you can see normally the flu season occurs every winter. 2021, we didn't have a winter season, but then we saw very unusually, we saw a summer season. So we saw flu go up quite a lot really during the summer of last year. And that's really unprecedented. We've not seen that before. Likely this is a result of the fact that there's now this immunity gap because we didn't see flu for 2 years, so that the immunity is now overcoming the seasonal forcing of winter. Normally, flu is very strongly seasonally driven, and that's why it doesn't occur in winter. But because there's this immunity gap, it shifts to summer. Because it was summer, though, it wasn't a very big season, probably because the seasonal forcing sort of kept it down a bit, and it did come down. And this is just to show you what we're seeing now. So this is our summer season. This is outpatient surveillance. This is hospital surveillance, and we are seeing flu circulating now in South Africa, and we expect the season to take off at any point. We haven't done a mathematical model for it, but I would project, that there is a substantial immunity gap. We haven't seen flu for 2 years, and so we should certainly be concerned and prepare for a heavy influenza season this coming winter, because now it's, as we go into winter, restrictions are relaxed, and there's no benefit of summer that might keep the flu down. And this is just to show where we are on our MEM curve. So it's sort of when it crosses into green and is sustained, that's when we declare the season. So we're really at the cusp. We expect any week now, perhaps even next week, it'll be sustained, and then we'll declare the start of the influenza season. And of course, that's of concern because we still have COVID circulating. I just have 2 slides here from the DATCOV data. These are prepared by Wasila just looking at children, just to show you what's happening with this current wave. On the left, you see admissions amongst children from the start of the pandemic. I asked her for this audience to really give it to you in fine age bands. So this blue is less than 1 year old, and then the orange is 1 to 11 months, gray is 1 to 4 years old, and then yellow 5 to 9, and so it goes up. And essentially, you can see all the different waves here. So you can see admissions in kids are going up, but not as high as in the Omicron wave, and also except in the 15 to 18 years, not as high as the or kind of around the same level, sorry, as the Delta wave. And this is just showing it in more detail. So we are seeing increased admissions in kids, but nothing sort of substantially more than previous waves. And of course, we know it's not really clear which of these admissions are attributable to COVID. Some kids may be admitted with other diagnoses and then test positive for COVID, because DATCOV doesn't distinguish that. Just this is my last slide on COVID. Just to look at the severity, just to reassure you, amongst the children admitted to hospital, compared, this is the third wave, this is the fourth wave, we see that there's reduced severity in all age groups, but also in children. So even though the admissions are kind of at rates similar to previous waves, the risk of severe disease or death in hospital is less. And this is my last slide, and I think it was because Mignon and Marty had asked me to do this. I've been meaning to do this for ages, but I haven't brought it up this way. I thought it's quite helpful for us to contextualize the burden of COVID in children by comparing it to the burden of flu and RSV that we see every year. So in this figure, what I've got here, at the top is hospitalizations and then deaths, and in the two age groups, less than 1 and 1 to 4. Here's flu, and these are for flu and RSV, it's estimates of the annual number of children admitted to hospital every year, and estimates of the annual number of children who die in hospital every year attributable to flu or attributable to RSV. And then here I just have the total number of COVID cases registered on DATCOV in hospital, either admitted or died. And you can see to date, this was, I think, yesterday, 15,000 COVID children have been admitted with a lab-confirmed COVID diagnosis. This contrasts with 44,000 children admitted in the average RSV season and 12,000 children less than 5 admitted in the average flu season. And then 379 cumulative COVID deaths, and then that contrast was 490 each year for RSV in hospital deaths and 248 flu deaths. So essentially the COVID epidemic to date is caused slightly more hospitalizations and deaths than a flu season, and less than one would see with an average RSV season. But I suppose to note, it does appear to be shifting somewhat to affect children more proportionately. And it will be very interesting to see how it lines up as it establishes endemicity in terms of burden. Lastly, all of our data is published weekly reports on our website, and you can really access all of this at any time, and to acknowledge many people who participate in surveillance. Thank you.
Sure. Thank you so much, Cheryl, for that mouthful. We really appreciate that. There's one question in the chat so far, and I'm actually going to leave it for later, because I think it would be nice to quickly hear from Shabir, and then we'll go ahead with our panel discussion and address that question. So, Mignon, if you want to go ahead and please introduce the rest of our panel.
Thank you, Shabir, for joining us, and we look forward to your presentation. We're going to do 2 short presentations, and then we'll move into the panel discussion. So thank you very much.
Thanks, Mignon, and good evening, everyone. So I'm just going to sort of supplement some of what Cheryl said, but I think a good starting point each time, as Cheryl has pointed out, is that RSV is the most important cause of hospitalization for LRTI, and that doesn't come as too much of a surprise to us. Including when the children are admitted for very severe LRTI or severe LRTI. But the other thing which I think is important to discuss in the context of respiratory viruses is the interaction of respiratory viruses and bacteria, because I do believe that some of the trends that we've observed in childhood pneumonia over the course of the past 2 years speaks more to the interaction of these pathogens rather than any pathogen on its own being responsible for the trends that we've seen in all-cause pneumonia. So when we look at the bacterial causes of pneumonia, the 2 that really stand out, especially for very severe cases of pneumonia, strep pneumonia and H influenza, and this is a non-typable H influenza. And I just ask you to keep this in mind as I go through the rest of the presentation. So historically, including in South Africa, what has been shown is a very strong temporal association between circulation of RSV influenza as well as pneumococcus. And this is prior to introduction of pneumococcal conjugate vaccine as well as after introduction of pneumococcal conjugate vaccine. So you see this very strong temporal trend. When you start getting peaks of RSV, you get an increase in pneumococcal pneumonia hospitalization, and similarly so for influenza. And I'm not going to go into the detail of the reasons for this, but it really speaks to the ability of influenza virus to increase the density of colonization, as well as increase the risk of colonization, and that ends up resulting in microaspiration. The virus itself brings about some sort of impairment of innate immunity in the lung, which allows for bacterial overgrowth. And hence what we're really seeing is an interaction of virus and a bacteria in the pathogenesis of severe pneumonia. So just keep that in mind because I'll touch on this. So the data I'm going to present are data from Soweto. This is ongoing surveillance program that we've had since 2006 for hospitalization at Krasani Bergwanas Hospital. And as you can see, the first big change in hospitalization rate for pneumonia across all age groups was following the introduction of pneumococcal conjugate vaccine, following which we showed about a 40% reduction in all-cause pneumonia hospitalization. And over the next decade, the hospitalization incidence across all age groups remained pretty much stable, very little change until 2020, when we saw this dramatic decline in all-cause pneumonia hospitalization. So this is all-cause pneumonia hospitalization, irrespective of which organisms are responsible. In tandem to this, what we've also been doing is looking at hospitalization for pathogen-specific causes of hospitalization. But before I go to that, what did we actually see? So the data that I'm going to present in the next few slides is basically looking at a historical average of 2015 to 2019, and then the incidence of hospitalization for 2020, 21, 21, 22, and this is starting from March, because that's when South Africa went into its high level of restrictions. So what we see in 2020 and 2021 and 21, 22 is about 50% reduction in all-cause pneumonia hospitalization. And again, this is data from Soweto. The sort of all-cause reduction in pneumonia hospitalization was evident across all age groups. In the less than 3-month age group, sitting at about 45%. In the older age groups, even a point estimate is slightly higher at 60 to 65%. So real reductions in all-cause pneumonia hospitalization. So looking at RSV more specifically, very similar to the trends that Cheryl had indicated. So this is mapping from March to February of each calendar year, starting in for historical average of 2015 to 2019, a very predictable outbreak that occurs year on year in Johannesburg prior to onset of COVID-19. And what we saw occurring in 2020, we started off with the RSV season gaining traction, but immediately after we went into high level of restrictions, it almost disappeared completely. And then unseasonally came back around about November. And that start in November continued right through, almost into, that's going on to the blue, went on into March and started to subside down about April, when we usually would get a peak. So we had this unseasonal outbreak. Looking at the incidence of hospitalization over that period of time, 50% lower incidence of hospitalization in 2021 and 61% lower rate of hospitalization in 21-22 compared to the historical average. And again, we see this sort of reduction in hospitalization across all age groups, perhaps slightly lower reduction in the less than 3-month age group. Obviously, the threshold for hospitalization in these children is substantially lower, which might influence the type of reductions, incidence rate reduction that we're seeing. But in the older age groups, again, we're seeing anything 65, 70% reduction in 21-22 compared to the historical average. So across all age groups, really seeing substantial reductions in incidence of hospitalization for RSV. Now, where are we currently? So this is the latest data until last week, and this shows what's happening in 22 now. Largely what's happening is that the RSV epidemic has pretty much returned to what it was pre-COVID-19. We're around about week 5, towards the end of February, we started to, we use a 10% positivity in 2 consecutive weeks as a threshold for the season having started, and that started around about the end of February. We have now peaked and very much subsiding. The positivity rate still remains relatively high at about 20%. But as Cheryl had pointed out, what is happening in tandem to this reduction in RSV hospitalization is beginning to see an increase in hospitalization for influenza. So the positivity rate for influenza in the past week in children that are hospitalized is sitting at 10%. So we are seeing this difference. Now, Cheryl had sort of alluded to whether there might be changes in terms of the age group distribution of RSV in a more recent period, especially in 2022 compared to earlier years. Certainly from the Soweto data, we don't see such a change in age group distribution. So this is looking at a percentage of RSV hospitalization across each age group in the different years in 2019 as a reference, as an example, 0 to 90 days were responsible for 47% of hospitalizations, sitting at 44% this year, and also in the older age groups, very little change. So we did sort of hypothesize as well that there might be this change in age group distribution, biased more towards an increased incidence in the older age group. But this is not what is materializing from the data that's coming through right now for hospitalization. So I'm not going to go into influenza. I think Cheryl has sort of already mentioned this again, where you basically saw almost no influenza in 2020-21, 99% lower incidence compared with the historical 5-year period before. In 21-22, some influenza activity, but again, reduction of 60% in incidence of hospitalization compared to the earlier year. So the last thing that I want to talk about just quickly is that we do see the changes in RSV and influenza-associated hospitalization, and I haven't really spoken about pneumococcal disease, but what NICD data has shown was a substantial reduction in invasive pneumococcal disease. And in colonization studies, we've shown that it's difficult to explain this reduction in invasive pneumococcal disease by virtue of a reduction in colonization, because the prevalence of colonization with pneumococcus has remained unchanged in 2021 and 2022 compared to in 2018. But where we do start seeing a difference is a 30% reduction in non-typable Haemophilus influenza colonization, as well as reductions in Moraxella catarrhalis colonization. Now, the reason why that's important is what I did sort of allude to right at the start, is that non-typable Haemophilus influenza contributes to about 10% of hospitalization for very severe pneumonia. So this reduction that we're seeing in all-cause pneumonia hospitalization is probably a combination of reductions in RSV, influenza, other respiratory viral-associated pneumonias, as well as interruption in terms of susceptibility to developing pneumococcal disease and consequently pneumococcal pneumonia, but also some reductions in other bacterial causes of pneumonia, such as NTHI. So let me stop there and happy to take a discussion.
Thank you so much. So some good news on that RSV that seems to be over like the worst, but like Cheryl said, we're not sure if there's going to be another peak. So I just want to quickly address some of the questions in the chats, and some of them might not be completely related to the data that you've just mentioned. So someone is asking, from what age group can we safely vaccinate peds patients against influenza? And how long should one wait after having an upper respiratory tract infection to get the vaccine for flu? So Shabir and Heather, perhaps, I don't know if you want to address this for us.
Yeah, I mean, it depends what age group you're talking about. To be honest, I'm not a fan of influenza vaccination in a 6-month to 5 age group. I don't think the vaccine achieves much. In fact, the incidence of influenza hospitalization itself probably makes it difficult to justify. The non-adjuvant vaccines, which is the only vaccine that we've got available currently in South Africa, requires 2 doses the first time the child has been vaccinated. And the data really it's not compelling to me in that it's going to make any material impact. The other concern is based on the Northern Hemisphere experience with the influenza season. In fact, the current influenza vaccine which they use, there was a mismatch to the virus that eventually started to circulate with no vaccine effectiveness demonstrated.
Sure. Okay, Heather, your feeling about this?
Well, I mean, the vaccine is indicated for children over 6 months, 6 months and older. I would say there are certain subgroups of children who one may be more likely to vaccinate, or vaccination would be more important in. Children with underlying chronic cardiac, chronic respiratory disease, children who are chronically on aspirin, immunosuppressed children, and so on. And while I accept this is definitely not a perfect vaccine, and probably what's important is to vaccinate vulnerable adults more than children, I do think that some protection is better than nothing. I also just want to respond to the point about RSV being over. In the Western Cape, we see a later season. And so Gauteng preceded our RSV, that RSV curve that Shabir has shown so nicely, and Cheryl as well. We are still seeing the full force of the RSV pandemic. Well, I wouldn't call it a pandemic, but RSV season. And we're not, I don't think we're on the downward turn yet. We looked at our data, Cheryl, and this is from the surveillance data, and we don't see an increased age of admission. And this may be that because older children just develop less severe disease, and that's corroborated by studies from around the world where yes, there has been a shift to, or there's been increased incidence of RSV following a disappearance or following lower numbers, and a shift to older children, but not necessarily to severe disease. Although in the US it was reported as severe, but for the most part, from most countries, Iceland, Europe, and so on, what's been reported is not more severe disease, in fact, fairly mild disease. I just want to add that one virus that hasn't been mentioned and that we're seeing a lot of in the West, well, certainly at Red Cross, which I know isn't the whole of South Africa, but still, is adenovirus. And we're actually seeing very, very severe forms of adenovirus, both respiratory, diarrhea, and also myocarditis kind of presentations. And I think we focus on the viruses which we can measure and which are routinely measured, but we shouldn't forget a virus like adenovirus. Just to add that in.
Yeah, so that's great because you actually answered some of the questions now that's in the chat and that we also will address a little bit later. The next question I quickly want to give to Cheryl. So Cabello has asked that the RSV cases, are they both public and private sector? And if so, what percentage rate are you seeing, which is private and which is public?
So our surveillance is only in public sector hospitals. Our surveillance is really Department of Health funded, and it's in government hospitals. But we do have another program. We track, we collaborate with Netcare, and we track their respiratory admissions, and we're seeing exactly the same trend in private. So I think the thing about respiratory viruses is they really are ubiquitous, and you know, you can basically infer if it's circulating in private, it's circulating in public, because there's so much mixing and in terms of their transmission. So I think the increases are in both, and we also get reports from the private labs that show us that I think it's in both sectors. And I agree with Heather. The timing is different in different provinces, and it's not quite clear, you know, whether, I think Gauteng seems quite convincing, but the other provinces may still be coming, you know, waiting to come down.
So it's interesting on that. Paul Sinclair, who's a pediatrician in Cape Town, also just said in the chat a lot of adenovirus and peaking RSV in private in Cape Town at the moment. And then Free State is seeing many ex-prem babies with low respiratory tract infections or bronchiolitis admitted to PICU. At the moment, 4 or 5 at Pneumonia PICU are these kids.
Yeah, so I think from a pediatrician, from a clinical perspective, it almost feels like the data doesn't do justice of what we are exactly seeing at the moment, because it feels like we are in the red. Our ICUs are full. We've got so many babies on CPAP. And maybe I just want to address this question to Cheryl. Like, what measures can we actually put in place with all these circulating viruses all at once? What can we do to try and decrease the hospital burden, to try and just prevent and kind of warn parents about what's going on? So what's your suggestions?
Well, so I don't know if I have suggestions. I mean, what we know, what Shabir's data shows, what my data shows, is that non-pharmaceutical interventions work to reduce respiratory virus circulation, and it's a combination, probably. Right? It's masks, which I'm sure we'll debate later. It's closing the schools. It's reduced gatherings, etc. But they work because that's what we've seen, and what we're seeing now is the rebound, because that lack of also what we know is there are incredibly high rates of infection every year that are undiagnosed, that are keeping the levels of immunity in the population up, and that's in adults and in kids, because it's not only kids that are spreading it. And when we don't spread them, then we create this gap, and that's what's driving this increase. And I mean, even rhinovirus, we haven't spoken about rhinovirus, but there's a lot of rhinovirus around, and really sick kids, enteros as well. But Yeah, so yes, if we had to have a lockdown, it would get it down. But I think the big issue around is what is proportionate, right? So what is proportionate? So a general public health community-wide measures probably are not proportionate to what we're seeing in the ICUs. And then with regard to more specific things, it's difficult, right? Kids are at school, and you don't want to keep them out of school. And I have kids at home, and we've been sick all the time, So I'm not sure if Shabir or Heather have more specific recommendations, but yeah, it is difficult. This is the respiratory season, and it may be worse. Probably it's going to be worse than for the last few years, even before COVID.
So if I can just maybe extend your question to Heather, in that I can't ever remember seeing this many babies needing CPAP and respiratory support in one go. As Marty says, it's nice to see the graphs, but for people on the ground, it really feels like it's crazy. It almost feels like we've got a pediatric pandemic like the adults had during COVID. So Heather, what is happening? Why is it so severe?
Yeah, I think, thanks, Mignon. I think some of the reasons have been alluded to: this vulnerability, lack of immunity, particularly to RSV and to influenza. I think adeno is circulating now, and we don't know the serotypes that are circulating, but it seems like a very virulent adenovirus infection. The other issue is, I'm not sure, and this is just a thought now, but whether our levels of immunization, for example, pneumococcal conjugate vaccine immunization, are what they should be. We know there were big gaps when there were lockdowns and there were unimmunized children walking around. My hope is that has been corrected, but what we're certainly seeing more than we've seen before are, for example, the impact of this COVID pandemic on the economy and on malnutrition in children. And I think many of the clinicians will corroborate that we are seeing levels of malnutrition in children that we haven't seen for quite a while. And so, I think this massive increase in severe respiratory disease is a function of circulating viruses, of an immune gap, and also of social circumstances, with increasing poverty, increasing malnutrition, and perhaps less immunization than has happened in the past.
Sure. Thank you for that. So maybe following on that, I would just like to ask Prof. Shabir, so now that we've seen a little bit of a decrease in RSV, and we're not sure if we're going to see an increase again, and it maybe fits in with some of the previous questions, do you think there's anything kind of preventable, especially in the little ones, that we can do to prevent a next wave of RSV, or should we just shoulder on, get our immunity back, and kind of just live through this?
Yeah, so I don't think there's any preventing the next wave. And certainly I wouldn't be advocating for us to go to higher level of restrictions to reduce the burden of RSV, even if it does, because it comes with huge additional costs. So unfortunately, we're going to need to just ride the wave. But just going back to your previous question, the previous discussion on why there might be more severe cases, so it would be good to understand what spectrum of disease you're seeing, whether you're seeing the typical bronchiolitis cases or whether you're actually seeing real pneumonia cases with RSV that ending up in hospital. Because if it is the latter, it could possibly be explained by what is being observed in the UK right now, and that they've actually seen an increase in invasive pneumococcal disease, both of vaccine and as well as non-vaccine serotypes in children, which is much greater than what existed before the COVID pandemic. And it's all about the susceptibility that has evolved, not just only against respiratory viruses, but also susceptibility that has evolved when it comes to risk of developing pneumonia from bacteria, including pneumococcus. So I'm not too sure exactly what sort of spectrum of disease you're seeing, but if you're seeing children with pneumonia that are being admitted with RSV, that spectrum of pneumonia is not RSV. That spectrum of pneumonia is more likely to be because of superimposed bacterial infections. But with regard to your other question, there's almost nothing that you can do. I think that I'm fairly confident that we're not going to see another RSV outbreak this year. I think RSV has pretty much returned to what it was before COVID-19. This particular season might be a bit longer than would have occurred otherwise, but I would be highly surprised if we see another resurgence take place with RSV in the next 4 or 5 months.
Great. Heather, your hand's up.
No, I just wanted to add, sorry. I think the principles of what prevented viral infections in the last 2 years could to some extent still be done. So avoiding of, crowded spaces, good ventilation, opening windows. I mean, RSV, don't forget, is a very important nosocomial, is transmitted nosoconially as well. And we're not very good in terms of careful hand washing between patients. So those kinds of measures of hand hygiene, of good ventilation, of outside, of avoiding closed, crowded spaces as much as possible are just the principles. I mean, of course, no one's advocating, definitely not another lockdown, and definitely not the kind of stringent measures that we saw. And mask wearing, which is contentious, but certainly does prevent spread of viruses in several studies. Also with RSV, I think, yes, it's a hard season to get through now. And Shabir, it's not pneumococcal bacteremia that we're seeing, but I completely agree with you that this severe disease is always bacterial viral interaction. And I'm sure you're right. This is maybe non-typable Haemophilus. I don't know what. But it's not bacteremic pneumococcal disease. But what I did just want to allude to is that I think in terms of RSV, the future is actually quite very promising. In fact, both, there are multiple studies underway looking at vaccine strategies, either immunization of pregnant women and long-acting monoclonal antibody strategies. Nirsevimab is the most, there have been 2 really good publications on nirsevimab, which is a long-acting monoclonal antibody. It's like palivizumab, but a single shot lasts for 5 months at least. And the protective efficacy for RSV in young infants is anything from 70 to 80% and even higher for hospitalization. And I think this is an intervention that we will see hopefully in the next few years.
Sure, at least some good news. So thank you so much for that. So the next question I want to just ask Cheryl, and you did show us that last slide was really looking at this question, because for us clinicians, it really feels like we've seen more RSV deaths in the last month that we actually saw COVID in children in the last 2 years. And I think there might be a little bit of a lack in data coming in from the last kind of 6 weeks of RSV deaths. But I just wanted to ask you a little bit about that data and your impression overall. So I could see the hospitalizations from RSV is like 3 times higher, but the deaths actually looks pretty similar.
So I think so there's a few things in that. So I know you'd asked the current RSV deaths, but really we can't track. Remember, COVID's the only disease we test for universally, right? Most hospitals, certainly in public, they don't test for RSV, they don't test for flu. The kids are admitted with pneumonia, but we know right now more than half of them have RSV, but it'll never be diagnosed. So to get our estimates of RSV burden, we base it on our systematic surveillance over several years, and then we infer from that, if so many percent is RSV, this is what the total burden must be. So that's, and there was a range around that estimate, right? So we're on the really higher end of the range, so maybe double the number of RSV deaths or hospitalizations. And I think so you can't really compare, but I think the reality is, and there was a question in the chat about RSV vaccines for young kids, right? COVID vaccines for young kids. Certainly the impact of RSV on children is much greater than the impact of COVID, even cumulatively throughout the pandemic, right? And what I showed was each year for RSV, we've had 4 or 5 waves of COVID. And so I think, I don't know the answer certainly for young kids. I think a lot of people are advocating for COVID vaccines, but there needs to be a discussion. I think what Heather's saying about RSV, immunoglobulin and vaccines is much more exciting to me than a COVID vaccine for young kids. And I think, probably this type of wave of other respiratory viruses can certainly have a bigger impact than COVID. And what will be very interesting is to see now as COVID becomes more endemic and we see the shift to more disease in kids versus adults, will it eventually sort of settle on being more like the other respiratory viruses and move away from adults? We don't know yet.
Thank you. And if I can just extend, while we're still on RSV, back to Shabir, you've made some really good points in the chat, Shabir. I don't know if you just want to share that with the rest of the audience.
Yeah, so I mean, there's 2 points. So just based on some of the feedback that I was getting about a clinical spectrum of illness, there was a suggestion that they're seeing a lot by way of lobar pneumonia. And that certainly is a good proxy for bacterial pneumonia. And it shouldn't come as a surprise that you're not seeing much bacteremia, because less than 5% of pneumococcal pneumonia will have bacteremia. So I think what you're describing really speaks to an issue of heightened susceptibility to superimpose bacterial pneumonia, pneumococcus, and perhaps even other bacteria. But that might well be driving this sort of unusual large number of severe RSV-associated cases that are ending up in ICU.
Great, thank you. So I'm going to switch tack a little bit, and I'm actually going to ask Shabir, I'm going to ask you again. So there's been many international reports of liver disease in children, and more than half the cases tested positive for adenovirus. So I've actually been in touch with some of my colleagues at King's College Hospital in London. They've transplanted about 6 or 7 kids this year already just with adeno liver disease, and we've seen some isolated cases at Red Cross with multi-organ dysfunction, and we've spoken to our colleagues across the country. So what's going on there? Do you think we'll see more of that in the winter? What is the prediction on that front?
Yeah, I mean, there's a lot of hypotheses as to the cause of. There's a lot of hypotheses about the cause of this hepatitis, and as you indicated, a large percentage of the children have had adenovirus 41. But again, that adenovirus 41 has been based on blood samples, and there hasn't been really identification of the virus in liver biopsies. So again, there's a lot of, I think it was a good review. In fact, I'll share a link that came out in Nature yesterday about the possible reasons, one of which has just been posted now, as to not really a weakening of the immune system, but rather an immune system that hasn't been otherwise primed from exposure to respiratory pathogens over the past 2 years. And how that could possibly increase the susceptibility to someone who gets infected with adenovirus who otherwise wouldn't have developed severe disease, going on to develop severe disease. Because when you get infected with any pathogen, your immune system induces a response that is not only targeted against that pathogen, but also cross-reactive to other pathogens, including other viruses. So I think there's still a lot of speculation. I do agree most of the evidence does tend to suggest it might be an issue, but I don't think the data.
Great, thank you so much. And then Heather, you mentioned the vaccines, the antiviral vaccines. I'm just curious, have you got any thoughts on antivirals that are available for either RSV or adeno? Because that's a discussion we sometimes have with you.
Yeah, there is no antiviral that I know of that is available that is effective for RSV. It's supportive care, as the clinicians here know, as well as for adenovirus. No antiviral that I'm aware of that is effective against, that can be used against adeno. Sorry. No.
And then on the same, while we're talking treatment, steroid use in COVID in kids, in adeno, RSV, what's your feeling on that?
I think the data for steroid use is not strong. As Shabir has alluded to, severe RSV is usually a combination of bacterial viral interactions, requires antibiotics and supportive care. And I think the same holds true for adeno. Where steroids have a role in adeno is probably in their ameliorating a long-term complication, bronchiolitis obliterans, where we know that high-dose steroids can actually ameliorate that. But other than that, I don't see a role for them in adeno RSV. In COVID, as we know, steroids are indicated for severe hypoxic failure in adults, or hypoxia, not severe, just hypoxia at all, and have been highly effective. And I think the same would hold true for children. I think we just need to bear in mind of all the COVID admissions, and Cheryl showed the numbers, if you look even in recently at the Omicron data from Schwani, the median duration of hospitalization was 2 days. And I think it was 12% of children required some form of oxygen. It's it's a mild illness. No mortality at all in children in whom COVID was attributed to be the cause of hospitalization, because 50% of, or more than 50% of those children, in fact, COVID was, or SARS-CoV-2 was identified as being not the cause of hospitalization. Children who are admitted for elective surgery or for other reasons, for example. But fortunately for us, I think COVID, remains a mild illness in children, although if I had a hypoxic child with SARS-CoV-2, I would use steroids.
Great, thank you very much. Mati, over to you.
I quickly want to ask that about RSV, because maybe it's just because I've seen so many, but I've had many babies that's oxygen dependent, huffing and puffing on oxygen for a while, that's little, that I bailed and I've given them a couple of days of steroids, and you don't know if it's time that get them off oxygen, or is it the steroids that's really made a difference, but then it kind of seems to have made a difference. So yeah, any comments on that, on doing that, or you just say there's too little evidence?
Well, I don't know if Shabir or Mignon or Cheryl want to say, I can't see the evidence is there for use of steroids in RSV. I think, again, with severe RSV, concomitant bacterial infection is much more likely. So I don't know whether steroids were also accompanied by adjustments in antibiotic doses and so on. And we know that a minority of children who get even RSV bronchiolitis are in fact bronchodilator responsive. So a minority of children, in fact, do have airway hyperreactivity. Maybe in that subgroup, there may be a place for steroids, but Marty, standing in your shoes, I would do whatever it takes. And evidence is one thing and the real world is another. So, yeah.
Okay, thank you for that. And that gets us to our next one about antibiotic stewardship. And doing more viral panels. And I think it's difficult, like you say, that it's normally a co-infection that makes the RSV children very sick. Can we justify doing more respiratory panels? Because I do think in the state you kind of feel everyone gets tested for COVID, but you almost need to sell a kidney to get a respiratory viral screen done on a child. So you don't really always have an idea what's going on. Can we justify doing more screens? At which point is a COVID just going to be part of your respiratory panel? And then to actually justify when you do get this result back to stop antibiotics sooner. I don't know if Shabir maybe wants to take that one on.
Yeah, I mean, I think even just testing routinely for COVID and for every admission, I think we need to reflect on what we're trying to achieve. Like for any other use of diagnostic, you use a diagnostic when it's going to influence management. And there's very little reason to be expanding the repertoire of viruses that we are investigating for. In fact, there's very little reason to do it outside of surveillance because there isn't any therapeutic that you're going to use. And it's not going to influence your management. If you get a lot of viruses and a child is in ICU with a lobar pneumonia, you're not going to pay attention to the viruses. You're still going to give that child antibiotics. So, I mean, I think what we can't afford to do is add to the fiscus burden of healthcare services by doing tests, which simply is not going to influence management. When we do the type of studies that NICD does and what we do, I mean, those studies are being done to inform public health at a different level and not at an individual level. So I really don't believe that there's much use. With regard to your question on steroids, as a last resort, yes, you need to throw everything that you've got to try to change a clinical course, but certainly wouldn't be advocating for steroids at an early stage because it does cause prolonged shedding of the virus, and it can actually worsen your outcome when it comes to bacterial pneumonia.
Cheryl,
okay, so
No, just to agree. I think we need, now is the time, right? We need to be having the discussion about shifting away from routine COVID testing. It's costing a fortune and it's not changing anything. And flu and RSV we monitor through surveillance. We've shown our surveillance tracks very well COVID just as it does flu and RSV. I think I just wanted to highlight also that I agree with Shabir. Often it doesn't change the diagnosis, but I think we just to mention, NICD does offer, pan-respiratory viral panels. We're not a NHLS diagnostic lab, but I think sometimes there are clusters of infection, like Heather described this increase in adeno in the Western Cape, that they test, I think, much more actively than other centers with pan-respiratory panels, which is why they picked it up, right? But if you're in a public hospital and you are seeing unusual respiratory presentation, unusual clusters, and you are worried what it is, we definitely offer that as a service to test. It's so I think routine clinical care, no, but there may be a public health indication or unusual clinical presentations that warrant investigation, and our lab is very happy to support that, and we don't charge for it. So there is some option for public sector doctors, and obviously in private, you make that decision based on whether you can afford it.
Yeah, I think it's just really nice to know who the culprit is, like who's to blame for that pneumonia. So it is nice to know. Anything that you would suggest? So we ever mentioned this high risk of hospital outbreaks, and we see that in the RSVs, and I fear for the preterm units if RSV must become an outbreak in some of the nurseries. Anything specific except like hand washing and like obviously be very diligent, but anything else that we can prevent to prevent hospital outbreaks? Should we cohort these patients that we're suspecting RSV together, or what would you suggest?
Sorry, is that directed at me?
You and Heather.
Heather's better than me. That's why. So Heather, she's got much more experience on RSV and nosocomial outbreaks. Go ahead, Heather.
Yeah, I think nosocomial outbreaks are potentially, really important. And firstly, you shouldn't cohort children together who are high risk. So any child who's high risk for severe RSV should not be, you should separate out the children who've got RSV. You've got a bigger child with a congenital heart disease or chronic lung disease, cohort them away from those children. And so I think, and this also comes back to the previous question, I think the value of testing is sometimes for cohorting and for the public health good. I think hand washing, good ventilation, a very careful hand sanitizing between patients. We know this is a problem. Busy nurses, busy doctors, they run from one patient to another, and there's a lot of potential for transmission that way. So I just think if we can be really careful and wash hands between each patient, open the windows when it's possible, and cohort as appropriately as possible. Obviously, in a Premi unit, you can't cohort. Premis are all cohorted together. Yeah. It's also often an adult person who can bring in the infection, and so the role of screening of staff, for example, is another area which is difficult, as we've seen in COVID.
Okay, yeah, thank you so much for that. So we're quickly going to go to influenza. And so we've had some predictions of what's going to happen, maybe a little bit more of an aggressive season for children specifically. Cheryl, what's your prediction of what's going to happen to children? And maybe I can ask Shabir as well, in terms of hospitalizations, do you think we're going to see much more influenza admissions?
So we haven't done a model, and there was a paper published, I think it was Nature or Science, where the authors actually said they don't think there's going to be a big flu season, because every year, some years we see H3, other years we see H1, so we're skipping years anyway. I don't agree with that at all. I think the fact that we saw a summer flu season, which we've never seen before, tells us there was an immunity gap, and I really think it didn't take off just because it was really hot and everyone was outdoors. So I think there's a good likelihood we'll have a big season, and if we have a big season, children will also be affected because the force of infection will be higher. And so I'll be happy if it doesn't happen. But we work on flu, COVID, RSV, and my life just goes from one stressful thing to the next. So the BA.4/5 looks like it's coming down now, but I'm just waiting for flu to mess up my June vacation plans. So I'll be happy if it doesn't happen, but I predict a big season and I would get ready for it.
Shabir, your feeling?
Yeah, so we'll have a bigger season than 2020 and 2021, but whether it's going to be a bigger season than what existed before COVID-19, I'm not convinced. I think based on what happened in the Northern Hemisphere, including the UK, during the course of their winter period, and they had pretty much gotten rid of all non-pharmacological interventions and other restrictions, they didn't see a massive spike of flu compared to pre-COVID era. So I think, yes, we're already seeing flu, but again, certainly I'm more optimistic. It's not going to be anywhere close to what we're seeing for RSV, and probably similar to what we saw before COVID.
Can I jump in there and ask, should all healthcare workers then be getting the flu jab?
Well, it might actually protect you against COVID as well. So, I mean, like I said, the problem with the flu vaccine right now is that it's even more unpredictable as to how effective it is going to be than before COVID, because of the absence of flu circulating largely for the past 2 years. And based on the US data, over the past winter season that just passed, the flu vaccine effectiveness, in fact, there wasn't any effectiveness reported. It was sitting at a point estimate of 10%. It's not going to do you any harm. And if you want to protect yourself and take a chance, probably get it. I don't know if you saw, there was an article that came out yesterday from Brazil, which talked about COVID flu vaccines in the early phase of COVID, where they showed an 89% reduction in severe COVID during the time of circulation of the wild type virus. But obviously you need to get your COVID vaccine to protect yourself against COVID.
So you can see Shabir is a flu vaccine skeptic, at least right now. But so I think the flu versus COVID thing, I think some of it could have been residual confounding. But personally, I would get the flu vaccine. I think most of the virus, I don't know if you looked on that graph, was H1N1. H1N1 is the most stable in terms of vaccine effectiveness. So H3N2 is the one that's more problematic. H1N1, it hasn't drifted that much. And I think if only for absenteeism, I mean, we've seen what COVID does to our workforce, right? If I'm right, if Shabir's wrong, and we have a big season, your clinicians are also going to all be off. And remember, there's still this COVID thing, so they're going to be much more likely to stay off if they're feeling sick. And so if in that way it could protect the workforce. And I would certainly recommend it. I had my shot more eagerly than usual for that reason.
And you want to go ahead with the COVID questions?
Yeah, I just wanted to ask, did you want to ask about Tamiflu for kids with flu? I mean,
yeah,
that's something that comes up quite a lot in private practice.
Yeah, so normally by this time of the year, we will get the message from the microbiologist or the virologist whether we're seeing more flu, and then tell us to start using Tamiflu more. So I don't know, Heather, what your feeling is about starting oseltamivir once the flu season starts, and for which kind of groups of patients?
Yeah, I think the data for oseltamivir shows that it reduces the duration of symptoms if taken early, and that's the key issue. I think has to be initiated sort of within 48 hours of symptoms. And certainly I think for severely ill children, I think it's worth giving, where you've got you expect or have a diagnosis of influenza. And for vulnerable children who are vulnerable to more severe disease, and where you've got a household contact, for example, and the child becomes symptomatic, I would also consider using it early in the course of the infection. It is the one antiviral we have that has some efficacy for influenza.
Great. Okay, so I'm going to move on to. Sorry.
Don't agree. I knew Shabir wouldn't agree.
Go for it, Shabir.
Yeah, no, I agree with that. I mean, I think
you
need to limit it to high-risk individuals. There's very little value to use Tamiflu in an otherwise healthy child. The chances of them progressing to severe disease is nominal, as Cheryl showed from our own data. So I think we need to be sensitive to cost. We can't just continue dispensing things for getting very little out value. There's not much value in reducing a duration of symptoms or shedding by 2 or 3 days. But there is value in protecting people from being hospitalized, and that needs to be measured based on the risk of progression to hospitalization.
Great. So I'm then just going to move on and say, we're looking at a 5th wave in children. Should we be pushing for vaccination of our vulnerable children? So we know that kids 12 to 17 are being vaccinated. As somebody who looks after a lot of immunocompromised patients, we hear that vaccines are being thrown away. Should we be, or potentially thrown away because they're going to expire, should we be pushing for this age group to be vaccinated? I don't mind who takes that one.
Absolutely, high-risk children should be vaccinated without any question, and they need to get probably 3-4 doses of vaccine for it to be of use. Whether other children should be vaccinated under the age of 12, I think I've spoken before on this, and there's very little value in vaccinating children against COVID when the risk of being hospitalized for COVID is so low, in addition to which, when vaccines are not protecting against infection, and where there's waning of immunity over such a quick period of time, and more so when there's this variants of concerns that are emerging that are antibody evasive. So again, high-risk children, in fact, I would go down to even 5 years. I think there's compelling reason why they should be vaccinated with 3-4 doses if need be.
Any other comments, guys?
I mean, I know I differ to Shabir on this, and I think we have a vaccine that is being widely given around the world for children 5 to 11 years of age. It's been given in the US. It's, in fact, today or yesterday, the FDA approved a booster dose for children who've received 2 doses of the 10 microgram dose and are 5 months after vaccination. So they've been given a 3rd dose. It's been given in Europe. It's been given, and I think we do have, yes, the vaccine efficacy, and I know Shabir is going to say it's not for Omicron, but in the 5 to 11-year-old NEJM publication, the vaccine efficacy is 90%. And I accept there's not great efficacy for infection, but we do see MISC-C, we do see long COVID in children, and I think these are vaccine preventable illnesses. And we have so much vaccine. We hear that it's being dumped, many of these doses. So I think there is some value in a vaccine program for children 5 to 11 years old that would offer some personal protection against, and I accept these are rare but severe complications of COVID, and that may offer some protection against infection. And the data that I've seen, for example, the data from Italy shows about a 30%, 40% protection against infection for Omicron. So it's not great, but we do have something. And I think we're doing children a disservice by not advocating for this. It's not like we're taking resources that would be used elsewhere.
So I'm going to give Cheryl a chance in a minute. I just wanted to ask, what's the holdup? So Cheryl, go for it.
So just to add, I think it's very important to distinguish a situation of vaccine excess versus paucity. The pediatric formulation is slightly different. So there is a discussion whether you can use the adult dose and just inject some of it. And I think the discussion is different, right? So if we have vaccine doses that aren't being used and they can be effective and there are people who want them, I think that then there's a good argument to be made. But I think actually what once we've no longer in the situation of all these doses that are not going to be used, we actually need to be lining COVID up against all the other EPI conditions and the products on the market like RSV and making proper, evidence-based decisions, looking at cost and cost effectiveness and life saves and hospitalization saves. So we're in a bit of a funny situation here with the Pfizer that's not been used. And I agree. I think if it's not harmful and it could offer benefit, then we should move towards that. But by the end of the year, those Pfizer doses will have expired. And actually now is when we need to be having the broader debate around, how we prioritize and normalizing COVID, that it's not this exceptional condition. What the holdup is, I don't know if anyone wants to comment on that.
Yeah, I'm just a quick response to Eva. I mean, if you've got extra doses of vaccine, by all means, use it. But certainly don't deviate resources in the public health sector from focusing on who requires it the most. And my biggest challenge right now is when we talk of vaccination of children, and we haven't got 90% coverage in adults, from a public health perspective, it adds very little value. But the other issue that I think we need to start recognizing is that we right now in a space where 80% of children have been infected and they've got infection-induced immunity. And there's compelling evidence which shows that infection-induced immunity in fact works better than only 2 doses of Pfizer vaccine in protecting against infection as well as against severe disease. So we're not dealing with children that are naive to COVID. They've developed immunity over time. And that infection-induced immunity probably is going to work similarly to vaccine-induced immunity in reducing the risk of long COVID. So much of the data on long COVID is not in individuals that are SARS-CoV-2 experienced, it's individuals that were SARS-CoV-2 naive in the early stage of the pandemic. So the calculus is constantly changing. And if we had better vaccines that were able to protect children from being infected and reducing mild symptomatic illness, certainly we should be using it. But where we don't have such vaccines, where there's extensive immunity that has evolved over time in an otherwise healthy population, I think the case for vaccination is diminished.
Shabir, we agree. I agree that the target for vaccination is vulnerable adults, the elderly, etc.
Yeah,
absolutely. But I do think that hybrid immunity is also emerging as an important construct. And hybrid immunity, it's a term that is being used for those in the audience who may not be aware of. It's a combination of, for example, natural immunity followed by boosted immunity due to a vaccination. And Shabir, you are much more expert at this than me. But I accept that most of our children, in fact, are infected. But giving them a dose of vaccine would provide that hybrid immunity that may boost them to levels that actually are protective, or may be protective against the next variant or against infection.
Great. So it's such a wonderful discussion. We were supposed to end at 6 and we're running way over time, but I just find it really fascinating. I'm going to end up with one last question. So what we've been hammered with in the media is, what about children with masks? And should we go around the room and see what people's feelings are about, should children be wearing masks? Do they still transmit as much as adults? What's the story on that? So should we start with Cheryl?
Okay, well, maybe in terms of transmission, I think the early data sort of for the original strain of COVID really suggested that adults were more important in transmission. But with the progressive variants, the Delta, there's not so much data on Omicron. I think, we see certainly in our studies that children are important in transmission, especially teenagers, introduce the virus into the house and they transmit more in the community. So children are important in transmission. In terms of masks, I know there's differing views on this panel. I believe that masks are certainly not 100% effective, but if you're indoors and they do reduce the amount of virus that's being released, and they induce the amount of virus that's that people are getting infected by, and on average, that use of masks overall does reduce transmission, and we see this. That's why flu and RSV, one of the major reasons why flu and RSV, went down so substantially in the past 2 years. I think the issue is about proportionality. So if we wore masks all the time, flu and RSV would also go away, and we'd save 10,000 kids a year who die of flu, and lots of them who die of RSV. But most of us believe that societally, it's not worth it, for us to wear masks all the time and for our kids to wear masks at school all the time. And so, it's where you sit. I think we really, now is the time we need to be having that conversation about lifting masks, not because they're completely ineffective, but just because, do we really feel that now the burden of respiratory disease we're seeing in kids and in adults is proportionate? And so certainly I would hope that it would relax quite soon.
Okay, but I'm tired of wearing a mask. Heather, what's your thoughts on that?
Look, I agree with Cheryl. I think masks had a very important place when the pandemic was in full swing and when there was limited immunity. We now know, as we said, most people have been infected. Almost all adults or children have had some form of infection, and hopefully some, others have been vaccinated as well. So I think there is still a place for masks in certain situations. I think and WHO actually revised their guidelines on masks recently. I think it was in March 2022. So actually those guidelines were produced just prior to Omicron. But we're now sitting with a very highly transmissible variant like Omicron and B4, B5, which are even more transmissible. And we're sitting with a population that is largely has some form of immunity. And in this context, where people are tired of wearing masks and they're not wearing them properly, masks are probably not doing what they did in the early phases of the pandemic. They're certainly not doing that. But I would say in situations of very poor ventilation, crowded, where if it's a very crowded classroom, there is a role for masks. For the most part, though, if we can ensure adequate ventilation, I think we can start to do away with masks. My sense is that the social cognitive development of children, their mental health and so on, has also, had taken a knock. And masks are part of that, not being able to read facial expressions, not being able to interact with people and form social cues and so on. So I am, my opinion is varying more and more towards we can be much more lenient with masks at this stage.
Shabir, so the kids aren't wearing their masks properly at school anyway, but the teachers are scared. What's your feeling on masks?
Yeah, so I think you might have heard my feeling in the public domain already. I mean, firstly, not all masks are equal, and I think we need to just get the reality check on that. And RSV didn't disappear in 2020 because of masks, because South Africa only started masking around about May, June, after RSV had actually disappeared. So I don't think we can attribute the reduction of transmission of RSV and flu in 2020 or 21 to masks. And how effective have masks been? Masks have not been effective in South Africa. You wouldn't have 90% of the population being infected with the virus at least once if masks were working as a public health measure. Yes, masks do provide protection. If you're wearing the right type of mask and if you're wearing it correctly, it will provide protection. Healthcare workers certainly still should be wearing N95 masks in hospitals. Should a teacher be wearing a cloth mask in the classroom when other children are not wearing a mask? The answer is no, unless they're wearing an N95 mask. What they need to do is they need to get vaccinated and protect themselves against severe disease, because if they don't get infected in the classroom, they're going to get infected in a shopping mall or in a spaza shop. So I think we need to just become more pragmatic about what has been achieved. Masks have not worked in South Africa in preventing infections. Had it prevented infections, 90% of the population would not have been infected with the virus at least once. So over time, in certain circumstances, it might have prevented a sort of outbreaks that might otherwise have occurred, but certainly in the South African context, difficult to make a case to continue with masks and to make an argument that it actually did assist in preventing infections.